Hi there, good afternoon. This is Dr. John Abad. I'm a surgical oncologist with Northwestern Medicine. Thanks for tuning in. I'm here to talk to you today about the surgical management of complex GI cancers. So that's of course a pretty big topic in my world. So just to narrow things down, I thought I would talk more specifically about the most common type of GI cancer, and that's colorectal cancer, and what the management is once it's metastasized or moved to other organs in our body. The most common one being to the liver. So this is something that over decades of time there's been an evolution of how we treat metastatic colorectal cancer to the liver. Thinking back to, even when I was in medical school, there was, just the thought of this disease metastasizing to the liver was really left with very little treatment options other than kind of palliative chemotherapy. Over the years, though, surgeons have begun to better understand the disease process of metastatic colorectal cancer when it involves the liver, and where we can help patients with this diagnosis of stage 4 disease and to remove the tumors and hopefully provide a curative intent operation with survival rates that exceed 50% over 5 years. So it's been, like I said, an evolution. A lot of it began with just our better understanding of how this disease, once it gets to the liver, the tumor biology, how we can use the liver's own regenerative properties to treat it. So my specialty being a surgical oncologist, I specialize mostly in liver, pancreas, and complex GI cancers. This is an area that we're deeply invested in. So one of the biggest strategies, and probably the one that we say is the gold standard for liver metastases from colorectal cancers, is to just simply remove it. So removing that portion of the liver with the tumors. Over the years, there's been a lot of controversy in what is a appropriate operation for these patients, and what things were kind of contraindicated. So what we learned over time is that because of the liver's ability to regenerate, we've actually been able to show that maybe the number or the location of the tumors is less of an issue, but it's more of whether or not you can successfully remove the disease that's there and provide patients with enough residual liver function to recover from the operation and do well over time. So I'd say most of us that treat liver metastases, we start this treatment usually with our colleagues in medical oncology, where we offer a systemic therapy option, usually chemotherapy, to shrink the tumors and to look at the tumor biology. So just to make sure that it hasn't metastasized to other parts of the body, and that this is a surgery that patients will benefit from. So if patients are responding to chemotherapy, then we generally get involved and come up with a strategy to remove the disease. And I think the more interesting cases over the last decade have involved complex tumors that are on both sides of the liver. So not just the right and not just the right only or left only, but when they're involving multiple areas on both sides of the liver. So the strategy is really to clear one portion of the liver first, and then there's things that we can do to cause that portion of the disease-free liver to now regenerate and grow, where we can be more aggressive about removing disease on the other side of the liver. Patients always ask, well, how much liver can you take? Can you take the entire liver? Well, no, we don't typically take the entire liver. This is an organ that is essential to living. We can remove up to about 80% of a normal liver, and patients will recover. For those that have received chemotherapy, it's closer to about 30% of the residual liver we like to maintain. So one of the things that we do in order to increase the size of the liver is a procedure called portal vein embolization, where we actually, our interventional radiology colleagues are able to embolize the blood flow to certain parts of the liver, then causing a shift over to the liver that we were trying to regenerate. And then once it's regenerated, we can actually remove the part of the liver with the disease. So it's often done in a staged form, so it's not all the tumors removed at one setting, but over the course of 2 operations, so we call a staged liver resection. And that's a very aggressive treatment, but we found that if patients are selected appropriately, the outcomes are excellent. We can see survival rates greater than 50% over 5 years. And that's compared to very low survival rates without any surgical intervention, and just remaining on palliative chemotherapy. So for folks that are not candidates for that aggressive approach, there's other things that we can do to treat liver metastases. There's ablative techniques where we actually put a needle into the liver using a microwave probe and actually ablate tumors in the liver. There's other things where we use internal radiation, so using a catheter that goes into the blood supply, into the arterial blood supply, into the liver, and actually provide a radioembolization approach. So we're basically treating with little spheres and microparticles into the blood flow to emit radiation to kill tumors. So that's also an important strategy, especially for folks that may not be strong enough or fit enough to actually go through a major liver resection. So there's a lot we've learned about how best to treat patients. Sometimes it's a combination of all 3 of those approaches. So it's a coordinated event, taking care of these patients. Oftentimes it's a medical oncologist, a surgical oncologist that has expertise in this area, radiation oncologists, interventional radiologists. So there's a lot of people involved in this. Again, I think depending on the patient, all of these can be tailored and personalized to the tumor and the disease. So that's an area where we've made a lot of important improvements in the treatment of cancer. Going back to treating stage 4 colorectal cancer, one of the areas that we've also seen some improvement is treating a very challenging group of patients that have something called carcinomatosis, or disease that's now spread internally to the lining of the abdominal cavity. So that is a very challenging problem that develops in people with advanced colorectal cancer. And one of the ways we've been able to demonstrate improvement of outcomes and some survival benefit for select patients is treating them with a type of very aggressive surgery where we actually remove all of the visible disease inside the abdomen, including the lining and the inside of the abdominal cavity. And then once there's all visible disease is removed, we treat with something called a hyperthermic intraperitoneal chemotherapy, or otherwise known as HIPEC. And this, again, very selective approach, but where we remove the tumor and then we put in these catheters inside the abdomen while the patient is still asleep on the operating room table, and then on a pump we circulate heated chemotherapy, so basically into the abdomen and out, and on this pump for about 90 minutes. And then once we're done, we drain out the chemotherapy, and then the patient recovers from the operation. Again, a very aggressive approach. All of these things, patient selection is the key. It's not one size fits all, and it's not a cookie cutter approach by any means. So having not just the expertise from people that can perform these operations, but knowing really the judgment and decision making, because it's very crucial if you're going to be having aggressive surgeries that you understand the risks involved and really who best would benefit from going through the operation. So there's a lot going on. It's an exciting area in GI cancers. When we talk to our medical oncology colleagues, they're often excited about slightly different things, targeted therapies. So, different molecular targets on the surface of tumor cells that they can target with different drugs and antibodies, using and even immune-based therapies. All of these we figure are going to play a big role in the future of cancer treatments. So I think I have a question here I could answer that just
Sure.
came in. Okay.
Michelle M. Is saying, pancreatic neuroendocrine endotumors are difficult to understand, and having a Whipple procedure is extremely scary.
It is.
Can you provide some incident data on non-functioning pancreatic neuroendocrine tumors?
Sure. So the question is about pancreatic neuroendocrine tumors, and so there's different types of pancreatic tumors. There's adenocarcinomas, which are probably the most aggressive, and then there's these neuroendocrine tumors, which can also be aggressive, but tend to be generally more indolent and slow growing. There's different types of pancreatic neuroendocrine tumors, those that are functional and those that are non-functional. When we mean functional and non-functional, we're talking about those that are secreting certain hormones that we then pick up, because people develop symptoms related to that. As far as the incidence, it's considered a rare type of cancer. On average, pancreatic neuroendocrine tumors, probably about 5 cases per million patients, so low incidence. In the past, I would say there was a higher incidence of functional tumors, but over the years, because of the way now with imaging and we're picking up a lot of more of these incidental non-functioning neuroendocrine tumors, so much that I would say now we're seeing about 90% of these tumors that we diagnose are non-functioning. The functional ones that secrete hormones, they can secrete hormones that affect our GI tract, so insulinomas, or an insulin-producing tumor of the pancreas, and gastrin secreting hormone pancreatic tumors. Those are probably a couple of the more common ones that we see as far as functional pancreatic neuroendocrine tumors. The treatment, and it sounds like this patient was talking about the Whipple procedure. That's a procedure otherwise known as the pancreaticoduodenectomy, made famous by Dr. Whipple. And I always joke around, although his name is attached to it, he didn't do a lot of them. This was a long time ago, and his outcomes were horrible. So it's improved a lot since Dr. Whipple. So it's a little jab at Dr. Whipple, but not to take anything away from him. But that procedure has evolved over time, like most procedures. It is an aggressive operation of, where we do remove the head of the pancreas, the duodenum, the distal portion of the bile duct, and oftentimes the distal part of the stomach, along with the proximal jejunum. So when that's removed, all the lymph nodes around the tumor are removed. Again, this is for tumors confined usually to the head of the pancreas. And then there's a reconstruction that happens after that tumor is removed, because now you have the pancreas, the bile duct, and the stomach that need to be reconnected. So there's 3 new connections when we do that operation. Usually that operation takes roughly 4 hours or so. It depends. Sometimes it's more complicated if the tumor is involving the blood supply to the liver, where we have to remove a portion of the vein attached and reconstruct that. So that's usually what a Whipple procedure entails.
What is the percentage of patients that need ongoing IV antibiotics following hospital discharge after a Whipple?
So the question is, how often do patients need IV antibiotics when they go home after a Whipple procedure? The indications for antibiotics after a Whipple procedure would be an ongoing infection, or either a superficial wound infection or a deeper intra-abdominal infection. Out of those three connections we just talked about, the one that's probably the most prone to have issues with healing is the pancreatic duct connection, and so there can be issues related to that where there's some leakage into the abdominal cavity, kind of setting up putting together a setting for an infection. I'd say on average that happens maybe 10 to 20% of the time, where patients will have a significant leak from that and need maybe some antibiotics when they leave the hospital. So it is an operation where there is still significant morbidity, although over time, obviously since Dr. Whipple, the mortality rate has really gone down significantly, to where in most high volume centers that are doing this, such as ours, it's down to 1% or less. So I think it's an operation where obviously there's a lot of need for expertise on the part of the surgeon doing it, in order to ensure the best outcomes possible.
What are the indicators that the pancreatic neuroendocrine tumor must be surgically removed? What symptoms might I experience?
Sure. So for pancreatic neuroendocrine tumors specifically, functional tumors more often, those need to be removed because of symptoms, related to if they do have an insulinoma that's driving down like their blood sugars and they're becoming hypoglycemic. Those patients, regardless of size, would need to have surgery to remove that. Non-functioning pancreatic neuroendocrine tumors, universally those greater than 2 centimeters are probably carry the largest risk of then spreading to the lymph nodes and then to the liver. So one measuring over 2 centimeters should be resected. Ones less than 1 centimeter, low-grade neuroendocrine tumors can be watched. The gray area is always the 1 to 2 centimeter, and so some of those can be resected or watched depending on what we're seeing. But that's an area where certainly that's kind of more considered a gray zone.
Sue is asking, with tumors located in the colon, can they be removed laparoscopically, and can you elaborate a little on this?
Yeah. So laparoscopic colectomies are essentially standard of care in this day and age. Minimally invasive approach where we insufflate the abdomen and use small instruments to then do the dissection and remove and reconnect the colon. That's standard practice. There are times where obviously an open approach is still the most appropriate if patients have a history of significant abdominal operations where there's scar tissue or the tumors large where it's connected to other structures where it's just probably would be just a better operation to do that open because the need to make a larger incision to extract the tumor anyway. So laparoscopic colectomies is very common.
Barb is asking, is surgery ever done successfully with stage 4 stomach cancer?
Great question. So for stage 4, I would say just in and of itself, if you looked at stage by stage, usually once it's, stage 4 where it's progressed outside of the stomach and the adjacent lymph nodes, surgery plays less of a role in successfully treating that. There are very select patients with stage 4 gastric cancer that have undergone successful surgery, but it's certainly not, I would say, common or standard practice. Those would include patients that have responded very well to systemic therapy. And so some of those patients involve, where there's lymph node spread beyond the typical region where we would be removing. Or even there are times where if they do develop peritoneal involvement, similar to what we were talking about with colorectal cancers, there are some studies looking at the role of that same procedure, that debulking and hyperthermic chemotherapy in that setting. I'd say that answer is kind of ongoing, and there are studies ongoing looking at that. So I would say it'd be a very, very select population of stage 4 that could benefit. I'd say most do not.
And what are the early warning signs of stomach cancer?
Great question. So early warning signs, the stomach, as you can imagine, one thing you may feel is that you're getting full faster, or what we call early satiety. That oftentimes will lead to weight loss, malnutrition, epigastric pain as it's growing and pushing out, sometimes anemia. So the tumor, as it's growing, can bleed internally into the GI tract, and sometimes folks will notice that they're anemic and they have dark stools, or hematemesis, where they're vomiting blood. That's also a symptom. But probably early satiety and weight loss are probably the two most common.
And if I have a family history of GI cancer, should I consider genetic testing or screening at an early age?
So if it depends on the type of cancer and really the age that they were diagnosed. There are several GI cancers that there is a hereditary link. Universally for pancreatic cancer, for example, if you're diagnosed with pancreatic adenocarcinoma, we do recommend genetic testing. Colorectal cancer under the age of 50 should go for genetic testing. There's other mutations in the GI tract, gastric cancers with certain mutations. So it really depends a little bit on the type of cancer in the GI tract and what that family history is. But certainly if there's a significant family history, I think getting an opinion of a genetic counselor is certainly appropriate.
And what are the most common and least common types of GI cancers?
Good question. So the most common is colorectal cancer, the one we talked about. So that's the one we actually probably have the best screening tool for. So, colonoscopies, starting at age 50, some are recommending starting at the age of 45. Certainly if you have a family history starting 10 years earlier than your whatever family member that was diagnosed, whatever their age was at, starting a decade earlier. So colorectal cancer is still hands down most common, and our best screening, is for colorectal cancer. The least common ones, pancreatic neuroendocrine tumors would fall into that group. Appendiceal cancers, so mucinous tumors that form on the appendix that then actually can spread along the peritoneum, like we talked about for those colorectal tumors. Those are pretty rare tumors as well. Those are also treated with that debulking technique where we put the chemotherapy in the abdomen for appendiceal cancers. So I'd say those are probably, looking at spectrums, the most common and least common. So yeah.
And what would you say are some of the risk factors for GI cancers?
So in general, some of the risk factors for GI cancers, I'd say things like diet, so processed foods, smokers, heavy drinkers, sedentary lifestyle, strong family history, all of those things in general, I think, we know them to contribute to risk for GI cancers. We're learning more and more about pockets of things, environmental exposures that can also contribute. Genetics is always something that we're learning more and more about. So it's always, we figure it's probably two things, right? Environmental or lifestyle exposure, genetics are probably two of the most important contributing factors.
And outside of genetic testing, what GI cancers can I be screened for?
So great question. So the question is about how can I, or what GI cancers can I be screened for? Colorectal cancer, obviously the one that everyone, if there's something I could get across to people today, please, if you're 50, get a colonoscopy. If you have a family history, please try to get that on the earlier side, especially if you know that person had a colon or rectal cancer as a young person. We definitely want, if there's one thing I can get across today is please get screened for that. It saves lives, it prevents cancers, it's our best screening tool for GI cancers. Other things, pancreatic cancer, there are more and more screening clinics that are coming up. We have a high-risk screening clinic here for folks that have genetic mutations that predispose them to pancreatic cancer, family histories, significant family histories of pancreatic cancer, or those that are prone to develop pancreatic cysts. So those patients are being actively screened. Certain patients that are high risk for gastroesophageal junction cancers or lower esophageal cancers from chronic reflux or Barrett's, those patients need to be screened. Gastric cancers, family history of genetic mutations, super important. If you live in Asia, certainly you're exposed to that risk is higher, and there's more screening efforts going on in Asia for gastric cancers than here in the kind of the Western world. So those will probably be the big ones. There's folks in regions of the world where there's a lot of hepatitis, so being screened for something called hepatocellular cancer is important. So all of those things.
Okay. Last question. Anal cancer has been in the news recently as being on the rise. Have you noticed this in your practice?
Yeah, we are seeing more anal cancers being diagnosed. That's been like that for about a couple of decades now. They're seeing this kind of slow rise. A lot of it is related to HPV infections, similar to oral cancers, cervical cancers. Those are related to HPV infections, and luckily it was in 2006 they developed a vaccine, and so now that's become pretty commonplace. And so what we predict now is that instances of anal cancer, we're going up, but it's going to peak out and soon go down as more and more people now are being vaccinated, and we're doing that preventative measure. So it is going up, but hopefully not too much longer. Okay. All right. Well, thank you for being with me today. I'm always happy to answer any questions. So, thank you to Living Well for putting together this opportunity. I probably should have introduced that at the beginning, but this is all brought to you from Living Well and their Facebook Live campaign. So Living Well does such amazing work for cancer patients, and literally touches thousands and thousands of lives each year, providing support not just for the cancer patients but the entire family. As providers, we're so indebted to the work they do. It's super important. Anything anyone can ever do to support Living Well too in the future, you're directly supporting cancer patients and their families, and it makes a huge difference. So thank you so much for tuning in, and have a wonderful weekend. Thank you.